Good evening, everyone. We're going to give folks just a few more minutes to join us here on our virtual platform, and we will get started momentarily. Well, good evening, everyone, and thank you for joining Inspira this evening for our webinar, The Sun, Friend or Foe. I'm Michelle Marshall. I'm the AVP for Oncology Services, and I will be your moderator for this evening's presentation. Before we get started, just a few housekeeping items for us to go over. First of all, just to note, this presentation is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Now, regarding our virtual format, you may know this already. Some of you may have joined us on a webinar before, but we cannot see or hear you. The only audio and video that is turned on right now is by our panelists. That being said, we want to make this an interactive experience, and we encourage you to participate by asking questions. On your screen, you'll see a box labeled Q&A. Feel free to submit your questions throughout the presentation, and we will address as many of them as possible at the end. Your questions will only be visible to our panelists, and you can keep your identity anonymous. If you want to do this, just check the box that says anonymous before submitting your question. Throughout the presentation, you'll see poll questions pop up on your screen. The questions will be multiple choice or true false, and we encourage you to participate. That's what makes it fun. Finally, you'll receive an email after this event with a recording of the webinar. So with these details out of the way, let's get started. The purpose of today's program is to provide an overview of skin cancer prevention and sun safety recommendations. You can see here on the slide the specific topics that we're going to cover tonight. To get us started, I'm very pleased to introduce Dr. Nandini Kulkarni, who will be handling the presentation today. Dr. Kulkarni, thank you so much for joining us tonight.
Thank you for having me.
Dr. Kulkarni is a surgical oncologist and the medical director of Inspira's Surgical Oncology Program, also a member of Inspira Medical Group. She completed her full medical school training, including residency and fellowship at premier academic institutions in India. And upon moving to the US, she then completed a second residency and fellowship with a surgical residency at Abington Memorial Hospital, followed by a fellowship at Fox Chase Cancer Center in Philadelphia, where she focused on complex general surgical oncology. She's double board certified in general surgery as well as complex general surgical oncology. Dr. Kulkarni specializes in breast cancer, as well as management of melanoma and other skin cancers, liver and pancreatic resections, gastric and colorectal resections, and soft tissue sarcoma. With over 12 years of surgical training and more than 2,000 surgeries, she combines her passion for learning and research with genuine regard for improving the lives and experience of patients suffering from cancer. Dr. Kulkarni, tonight we're going to tackle our love-hate relationship with the sun. I think we've all gotten pretty familiar with the dangers of prolonged sun exposure and its link to skin cancer. In fact, skin cancer is the #1 most common cancer in the US, with 1 in 5 Americans developing some form of skin cancer by the age of 70. I know you'll cover this fact and some others, some of the other dangers a little later this evening, but let's start tonight on a more positive note, as there are plenty of benefits to the sun. So let's see what our audience thinks about the benefits of the sun. Here's one of our first poll questions. Which of the following are benefits of sun exposure? Increased levels of vitamin D, enhanced mood, improved sleep, or all of the above? Go ahead and take a minute to log your responses. We'll close that out here in 3, or now, 3, 2, 1, real fast. Let's see what we thought. Okay, so we've got a pretty smart audience. All of the above is actually correct, and I'm going to turn it over now to Dr. Kulkarni and let her walk us through some of those details.
Yeah, absolutely. I think, most of you got those benefits absolutely right. who doesn't love being out and about on a sunny day? Talk about today and yesterday, for example, great weather. Sunlight is a natural trigger for the release of one of our brain hormones called serotonin. Serotonin is actually associated with us being, staying calm and focused and basically enhancing a happy mood. I'm sure, a lot of you have experienced whenever you have back-to-back rainy days and those thunderclouds and showers, you start to get a little depressed. It's a real thing. It's not just in the mind. Low levels of sunlight actually cause a dip in the level of serotonin and result in what is known as seasonal affective disorder, which actually makes you feel blue. Sunlight is also associated with strong bones. Believe it or not, sunlight is one of the main triggers for the body's production of vitamin D. So a moderate exposure to sunlight does boost your body's production of this essential vitamin. The daily requirement for adults is anywhere from 600 international units to 800 international units in slightly older individuals. And believe it or not, about 5 to 15 minutes of sun exposure, about 2 to 3 times a week, is more than adequate to provide the daily requirement. Besides, we have to remember that there are dietary sources for vitamin D, so it does not require you staying out in the sun for prolonged periods of time to provide this essential vitamin that you need for your bones. There's a ton of other benefits, and what's on this slide maybe covers just a fraction of those. Cancer prevention, people are looking into the possibility of regular exposure to sunlight actually preventing certain cancers. Skin healing, we're here to talk about skin cancer, but again, in moderate amounts, sun exposure can actually be used to heal conditions such as psoriasis, eczema, jaundice, and even acne in certain situations. And it's the UV component of the sunlight that helps with that. There's also a lot of ongoing research for benefits in autoimmune disorders like rheumatoid arthritis or systemic lupus erythematosus, which is known as lupus in a lot of layman terms, inflammatory bowel disease, and even thyroid conditions.
So it's clear that there are some real health benefits of sun exposure, but considering that we're only about 8 minutes into our presentation tonight, I have a feeling that the risks of prolonged sun exposure are going to be pretty extensive. So let's shift our attention and talk about those and start with a poll question for the audience. I think it's probably a pretty easy one. True or false? Getting a tan from a tanning bed is safer than being in the sun. Go ahead and submit your responses. I'm going to close this out here. 3, 2, 1. Let's see what the audience thinks. Oh, they're brilliant. There's been a lot of education that's gone on about this. If we had asked this question 15 years ago, I think the response rate would probably have looked pretty different. But Dr. Kulkarni, why don't you tell us a little bit about why that is actually false? Talk to us about the risks of prolonged sun exposure, including tanning beds.
Right. So, to understand why prolonged sun exposure is not a good thing, I think a little bit of understanding of what exactly do we mean by getting exposed to sunlight, because it's not as simple as that. Light it can be broken down into different components. The part that is visible is the center of this diagram here, which is the rainbow colors, right? And that's what we see in normal life. But there are wavelengths that are shorter and longer than normal visible light. And ultraviolet radiation is a part of that electromagnetic spectrum that is not visible to the naked eye. UV light can be classified into 3 types. So you have UVA, UVB, and UVC. And what we see is basically skin damage that can occur from exposure to these UV rays. A tan is not a good thing whichever way you look at it. A tan is actually the body's way of trying to protect you, trying to warn you from the fact that the sun is causing damage to your DNA. So as the sunlight starts damaging the DNA, the body starts sending pigment cells, that's the melanin, up into the skin. And that's your body's way of trying to protect your skin from getting more damaged. So if you look here at the A rays, they account for almost 95% of the UV radiation reaching the Earth's surface. They are less intense than the UVB, but they are almost 30 to 50 times more commonly prevalent in the sunlight. So they are present with relatively equal intensity during all the daylight years and throughout the year. They can penetrate clouds, they can penetrate glass, and most importantly, tanning booths primarily emit UVA radiation. So when we start thinking that we are safe if it's a cloudy day or if you're indoors, that's not necessarily true, because this form of UV radiation is actually penetrating all of that cover. Now, when we turn to UVB rays, they are the chief cause for skin reddening and sunburn, and they tend to damage the skin's more superficial layers. So they actually do play a key role in the development of skin cancer and contribute primarily to tanning and photoaging. So what photoaging means is basically prolonged exposure to sunlight tends to change the tone of your skin. And I'm sure you may have noticed in your friends or relatives who've been, sunbathers all their life, there is a change in the consistency of the skin and in the coloring of the skin, and that's termed photoaging. So the intensity of the UVB rays tends to vary by season and location and time of day. And especially in the US, the highest, most significant amount of UVB hits us between the hours of about 10 a.m. and 4 p.m. between April and October. So, when you're out there in the middle of the day, standing 2 hours under the sun, these UVB rays are relentlessly harming your skin. They don't significantly penetrate glass. So, you may be safe from the UVB rays, but don't forget that the UVA rays are still penetrating glass as you're inside.
That's a great overview of the difference between the two and the unique risks that they pose, each one of them. So a question I've heard before that I'd like to pose as a poll to the audience is related to our unique skin tones. So the question is, true or false? Dark skin does not need sunscreen. Let's go ahead and give you a couple moments here to complete that question. True or false? All right, let's wrap that up and see what our answer is. Very good again. This audience is smart. So the correct answer is in fact false. So Dr. Kulkarni, can you tell us a little bit more about skin tone and what it does or does not mean for us as we think about sun safety and skin cancer prevention?
Sure. So that's actually one of the most common issues that we face in our office, is trying to explain to patients the importance of sunscreen. A lot of us, including myself, we are brown skinned or dark skinned, tend to think that the sun doesn't really damage us. Now this chart over here kind of goes over the type of skin types. So the highly sensitive, so if you look at the number 1 on this diagram, these are very fair, individuals, often freckles. A lot of them will say, oh, Irish descent. And, sure enough, Irish, German, that Eastern European descent does tend to have that kind of a skin tone, and they burn easily. They tend to, they're very sensitive to even small amounts of time in the sunlight. They tend to burn easily and are probably at the highest risk for the development of skin cancer. Now, as your skin tone tends to get darker, there is definitely a built-in resistance to getting burnt and, the ability to tan, and therefore a slightly lower risk of developing skin cancer, a higher resistance to developing skin cancer. But the fact is that even the darkest skin tones are not free from the possibility of damage from prolonged sun exposure. And in fact, what happens is that in darker skin tones, it's sometimes harder for the patient and the physician to identify any abnormalities that could have been easily caught in a fairer skin tone. And so actually patients tend to present later and with more advanced stages of disease. So it actually makes it a little bit dangerous because you tend to present in a later stage of the disease. So by no means should you assume that just because you have a darker skin tone, can you avoid being, avoid applying sunscreen when you're in the sun. So this is a little bit of an overview. I thought it would help to understand why we say that the skin type doesn't necessarily protect you, that a tan doesn't necessarily protect you from the development of skin cancer. So what the excessive UV radiation is doing is that it's breaking your normal DNA. It's producing genetic mutations. So if you look at the very first strand of DNA here, the crisscross strand, that's a normal DNA. And now when you have these incoming UV rays, what it's doing is it's breaking the normal strand, and that's a mutation. So if you look on the little cartoon on the right side, it shows how a single cell that has now gotten mutated slowly starts developing more such damaged cells, and that's called hyperplasia. Eventually that hyperplasia then goes on increasing and becomes a precancer or an in situ cancer. And then eventually that cancer, basically that in situ cancer, starts penetrating the deeper skin layers, and that's when we develop invasive cancer. So when you're trying to get into a tanning booth and get a tan, what you're actually doing is generating more breaks in the DNA, causing more mutations, and as a result, ending up with a higher risk of skin cancer in your lifetime.
That's really interesting. And I never really thought about it that way, that the sun exposure can fundamentally alter our cell's DNA. So with that in mind, here's a follow-up question for our audience. Another poll for you. This one's another true or false. Skin cancer takes years of exposure to develop. Do you think this is true or false? Give you just another couple moments here. All right, let's see what our survey says. Okay, we're interesting. We're a little split here. And that's kind of to be expected because Dr. Kulkarni's laughing. This can kind of be a little bit of a trick question. So tell us about this, Dr. Kulkarni. 60 you're saying false, 40 you're saying true. Tell us the answer.
Yeah, I was teasing you that it is indeed a little bit of a trick question. So the concept to understand here is that age is not a barrier to developing skin cancer. I think that is the main purpose of this question. Just because you're 20 or 21 or 25 does not mean that you cannot develop skin cancer. It doesn't mean that you're invincible, right? So using sunscreen, using ideal sun protective behavior is important. And in fact, inculcating that from a younger age is really important, because if you look at statistics, the type of cancers in the age group of 25 to 29, the most common type of cancer is actually skin cancer. If you go to an even younger age group, so between 15 to 29, that skin cancers become the second most common cancers that are seen. So, although you won't see a lot of cancers in that age group, the most common cancers tend to be skin cancers in that age group. Now, having said that, you do need cumulative sun damage to develop skin cancer. So you will notice a little bit of a time lag between when you were exposed and were maybe careless about your skin protection and when you actually end up developing skin cancers. A lot of our baby boomer generation that laid out in the beach with the tanning oil and the reflectors, are now seeing us with a lot of skin damage, and that is slowly progressing into the formation of skin cancers. And there's a wide variety of those that we will be discussing later in the talk. So spot on, you have the types of skin cancers and this type of skin damage that you can see, it starts off with some of the precancerous conditions. As we just discussed in the diagram, you don't go from normal to skin cancer, from in a moment. You go through certain changes, and some of those changes are warning signs. So those precancerous conditions like actinic keratosis or atypical moles are your warning signs. And then the actual types of skin cancers could be basal cell cancers or squamous cell cancers, which are very common, both of those. And then come the more deadlier version, which is melanoma. The last cancer that is very rarely talked about, but is extremely deadly too, is the Merkel cell carcinoma.
So let's talk about each one of those in a little bit more detail. So we'll start with our precancerous conditions here.
So actinic keratosis, or AKs as dermatologists like to call them, are basically these dry, crumbly, scaly lesions that develop in sun-exposed areas of the body. I'm sure you have grandmas or grandpas that, you notice a lot of the changes on their forearms and, face, exposed surfaces. They can also be seen in patients who've had other forms of UV exposure, such as tanning booths. So if left alone, a lot of these will change over a period of time into squamous cell cancers. And treatment of these usually happens in a dermatologist's office in a wide variety of methods. It can be removed surgically, or they may just scrape the lesion, or they may use cryotherapy or freeze it basically, or use laser excision. Sometimes if it's very extensive, they may even recommend use of topical creams like 5-FU or imiquimod. Then you have these atypical moles, or what we call technically a dysplastic nevus. These are unusual looking, but they are benign moles. Now, the more the number of moles, the higher the risk of melanoma. So generally, more than 10 moles has been shown to have a 12% increase in the risk of melanoma. And you actually have an atypical mole syndrome, which requires, at least the presence of 100 or more moles, at least one or more of the moles to be more than 1/3 inch or larger, and at least one or more moles that is atypical. In fact, the familial atypical multiple mole syndrome, or multiple mole melanoma syndrome, or the FAM syndrome as we call it, is a combination of atypical moles and a family history of first or second degree relatives with melanoma. So these are patients who tend to have a very high incidence of melanoma in their lifetime. And this kind of dials back to that question about, age and sun exposure. If you have a family history, a genetic risk for the development of melanoma, you're going to see those changes happen sooner, because there is an inherent tendency already to have genetic mutations, and then the sun exposure kind of acts as a second hit in those situations. So to touch upon and start explaining, what type of skin cancers there are, I would like to go through a little bit of the basic anatomy of the skin. I think it's always a good thing to understand what is normal, and that helps you to understand what's abnormal a little better. So this kind of gives you a little bit of an idea of the layers of the skin. You have superficial layers, which is the epidermis, and then you have the deeper layers, which are the dermis. And as you can see in this diagram, most of the hair follicles and the sweat glands and other glands are actually situated in the deeper layers and kind of make their way up towards the epidermis. Now, when you have these different cancers, they start on the top layers and kind of start penetrating downwards. And some degree of aggressiveness is related to how much they can penetrate through the skin. So if you look at the first one, the squamous cell cancers, they tend to be very superficial cancers. Whereas the basal cells, they're also known as rodent ulcers, and they tend to burrow through the skin at a deeper level. The good part being they don't really tend to spread to other parts of the body. So although they may be locally invasive, they don't intend to spread to other parts of the body and cause death as a result of that. Now, a melanoma, on the other hand, is sneaky in that sense. It tends to not only burrow deeper into the skin, it also spreads laterally under the skin. So what you see on the outside sometimes might be just the tip of the iceberg, and it's actually spread much deeper into the skin. Now, as it does so, it can also invade blood vessels, it can invade lymphatics, and so it can spread to other parts of the body, and that's what makes it more dangerous. So we're going to touch upon each of these cancers, in some basic detail without hopefully not grossing you out too much. Basal cell cancers are the most common skin cancer and actually account for more than 4 million cases diagnosed in the US every year. So as you saw in the first diagram, they tend to arise in the epidermis in the basal cells and generally will not spread to lymph nodes or other parts of the body unless it's very advanced. They can appear as a reddish patch or an open sore. They may look like a shiny nodule or even like a pink growth or scar-like area, as you can see in some of these diagrams. Now, squamous cancers, on the other hand, they are the second most common skin cancer, and they arise in the most superficial layers of the skin or the squamous cells in the epidermis. You see almost 1 million cases annually in the US, and about 8 to 9,000 people can die from it. Now, the reason being the squamous epithelium is present not just on the skin, but it's also present on the inner lining of our mucous membranes and in the genitalia. So those cancers tend to be more aggressive. The inner cancers tend to be more aggressive as opposed to the skin cancers, which are not as aggressive. So squamous skin cancer causing death is quite a rare situation. They can present as persistent, thick, rough, scaly patches that bleed. A lot of times patients will say, oh, I've had this wound and it just won't heal. And it's actually a developing squamous cancer. Sometimes they look like warts or may appear as open sores with a raised crusty border. And you can see some of these examples in these diagrams here. So basal and squamous cell cancer treatment, we've lumped together for a reason. Both of them, as we discussed, are not as deadly. They're more local, related to the skin, and can be easily treated in a variety of methods. When you see so many different types of methods of treatment, it tells you that it's a pretty easily curable type of cancer. So one of the common approaches to these cancers is just surgical excision. So, removing them by an operation where you make, take out a little bit of normal skin around the lesion, and then you sew the skin together, or sometimes you have to apply a skin graft. And even more popular version of this surgery that is employed especially in situations where the cancer is on a sensitive area like the face, is what's known as Mohs surgery. And I'm sure a lot of you have heard that, or maybe some of you have even gone through it. And basically what they do is they remove the lesion and then just little slivers of skin beyond that. And every time they remove a sliver of skin, they check under the microscope to see if there are any more cancer cells, and they can stop as soon as they don't see any cancer cells. So obviously that limits the amount of normal skin that needs to be sacrificed, tends to be a more cosmetically pleasing result. There's other types of treatment. You can use freezing treatment or cryotherapy. You can dry out the tissue or desiccate it. In certain situations, if the patient's really sick or if it's in a very sensitive spot, radiation may be used. Radiation can also be used in addition to surgery for a cancer that's really penetrated deep. And then, as we had mentioned before, there are some topical medications like anti-cancer creams, basically like 5-FU and imiquimod, that can be used, especially if a patient has so many lesions that you can't possibly remove all of them. Now we come to the more, our adversary here, if we were to say, the melanomas. So surprisingly, they account for less than 1% of all the skin cancers, but they are the most talked about because of their outcomes and their deadly nature. So they originate in the pigment producing cells, or what we call melanocytes, which are in the bottom layer of the epidermis. So they start off superficial, and they start off looking like moles. In fact, some of them will develop from moles. A majority of them will be either black or brown and kind of easily stand out against the skin, especially if you're fair-skinned. but they can be skin colored, they may be pink, red, purple, blue, even white, and may not look anything like our normal concept of a melanoma. So the key is that if you have a lesion that doesn't quite look right, just because it's not brown or black does not mean that it's not a melanoma. It still needs to be checked out. So this diagram goes through a little bit of the stages of the melanoma. You know, anytime we talk about a cancer, we like to appropriately stage it, because then that explains universally exactly how deep it may have been, or has it gone to lymph nodes, has it spread to other parts of the body, and accordingly, we can give a better idea to the patient as to what their cure rate is and what other types of treatment besides surgery, or do they require other types of treatment. That's what is defined by the stage of the melanoma. So if you look at the earlier diagrams on this picture, it talks about stage 0 melanoma, which is the in situ version, which is basically it has not yet penetrated through the basal layers of the skin. But then you start with the stage 1 and stage 2 melanomas, which as you go deeper into the skin, the stage kind of goes on upgrading. Stage 3 melanoma is one that has gone from the skin to the lymph nodes. And then stage 4, as you know, probably a lot of you know, is melanoma that has gone to other parts of the body. And you know, more commonly it will go to the lung, or it can go to the brain, but uncommonly it can even go to organs like the gallbladder. So stage 4 can be fairly invasive. Now, when we talk about treatment options for a melanoma, you know, primarily the bulk of the treatment options are surgical. So if it is an early stage melanoma or an in situ melanoma, then just removing the tumor is adequate. Now you remove it with a wide enough margin so that you account for those cells that we talked about that kind of penetrate under the layer of the skin and try to move away from the primary cancer. So if you have a superficial melanoma, you may want to go about 1 centimeter away from the lesion. If it's a slightly deeper melanoma, you may even go 2 centimeters away from the lesion in order to get all of the cells. Now, as the melanoma becomes deeper, you start worrying about whether or not it has gone to lymph nodes. And so in those cases, you may want to do a sentinel node biopsy. What that means is basically you inject a dye around the cancer, and that dye spreads through the lymphatics to the lymph nodes, and you can identify exactly which lymph node is likely to be affected, and you biopsy those targeted nodes and check if they've got tumor in them or not. If there is tumor in those nodes, there is a possibility that you may be suggested to have a more wider workup and make sure that the cancer hasn't gone to other parts of the body. At the same time, you may be referred for additional treatment, either in the form of surgery, like a complete lymph node dissection, where we remove all the fatty tissue in the area where we found the lymph node, in the hope of getting other lymph nodes that might have been also affected by the tumor. More importantly, when we know that the tumor has gone to the lymph nodes, we want to start you on a treatment that can help prevent the spread of the tumor to other parts of the body, while at the same time curing the stage 3 melanoma. And that is primarily immunotherapy. Immunotherapy refers to treatments that enhance your own body's immune response and therefore help to fight the cancer. There are other types of treatments called targeted treatments or targeted therapy that basically attacks specific mutations, and we have to check for those mutations before we can initiate that kind of treatment. Chemotherapy is very rarely used in melanoma, you know, especially with the advent of some of these newer treatments like immunotherapy and targeted therapy. But in certain specific situations, especially if you've had spread of the melanoma to the surrounding skin, say for example in your upper extremity, and there are a lot of nodules that have been affected, that have affected the skin, you can use just an isolated limb infusion or isolated limb perfusion, where we basically circulate the chemotherapy only to that limb. This basically kills the tumor cells, but it prevents the chemotherapy from circulating through your entire body And therefore, the common side effects of chemotherapy like nausea or hair loss can be avoided in that situation. But it's a very, very specific indication where you can use that. Radiation, not as common, very, very specific indications where radiation can be used to kind of heighten the effects of surgery. So once we know, what we are dealing with, how to prevent it or how to detect it. This slide basically focuses on early detection. If you were to identify a cancer in its early stages, we just saw that you could get away with just a small, removal of the tumor with some surrounding skin. So much easier situation than waiting until it spreads to deeper layers. So how do we identify it? And this acronym here, the ABCDE, has been used commonly to educate patients and to educate the general public of how we can look at ourselves and identify if something's not quite right. So the A stands for asymmetry, and the B stands for border. Now, both of these are kind of overlapping terms, but basically what we're looking at is if you have a round mole that's perfectly symmetrical and with even borders, it's more likely to be benign. But if you look at the picture under it, you see how the symmetry of the lesion changes and the borders start becoming more irregular, and that's a very concerning lesion. The next is the C, or the color of the lesion. Generally, if you have a mole, you'll notice that it's an even brown or maybe a dark brown color. As the changes of melanoma start creeping in, you will see that the lesion develops new colors. It may, part of it may become a darker brown than the rest of the mole, or it may actually become black. And those are sure shot warning signs that should head you off to a dermatologist right away, or to your primary care physician, whoever's, whoever can biopsy the lesion. If you have a surgical oncologist in the area, that's a good resource as well. And this is the time to contact them. D stands for diameter, which is basically how wide is the lesion. So general rule of thumb is if the lesion is smaller than the eraser that's at the tip of that's on the head of a pencil, if it's smaller than that, you're okay. If it crosses that diameter, that's not normal. And then above everything, above the ABCDs is the E, which stands for evolving. Something that's changing over a period of time is probably the most concerning situation. So, something that's been light brown all your life and now it's starting to change colors, or something that's been round all your life and all of a sudden it's developing these little feet crawling out from either side of it. Those are the evolving changes, and you should bring those to the attention of your physicians as well. The last type of cancer is what I had talked about, is probably the deadliest of them all, is the Merkel cell cancer. It's about 40 times rarer than melanoma, and I'm positive most of you have probably not even heard of this tumor because it is so rare. It's really not seen in the general community. It's far more aggressive. It kills almost 1 in 3 patients compared to 1 in 9 for a melanoma. It tends to arise in what is known as Merkel cells. These are supposed to be associated with the touch sensation. So they're just as widely prevalent over our skin, and can be just as exposed by the UV radiation. If you develop a Merkel cell cancer, it is treated in a lot of similar ways to melanoma. You have to excise it very widely. You have to check for lymph nodes. We have to make sure that it's not spread to other parts of the body. It has been shown to be associated with immune suppression. So patients who have undergone a transplant, say of their kidney or the liver, and they are on immune suppressive medications or other types of autoimmune disorders that tend to suppress your immune system, can make you prone to this kind of a cancer.
Well, that has been a really helpful overview of the various risks, the types of skin cancer and precancerous lesions that we might encounter, and really what we should be looking for. So let's shift gears now and spend our last few minutes of the formal presentation talking about prevention. Like so many illnesses, I think prevention it's much easier to prevent than it is to treat. So let's start with a poll question about prevention. When it comes to sunscreen, the higher the SPF, the better. True or false? I'll give you just a minute here to respond. All right, let's close it out and see what we think. Okay, we're pretty split here. 62% true, 38% false. Another one that's slightly a trick question. So Dr. Kulkarni, why don't you tell us a little bit about sunscreen and elaborate on what the answer is and what it means?
Yeah, so you know, it's obviously it's a question of, you know, choosing the right sunscreen. You walk into the market today and there's these, you know, million different brands, and you know, some talk about just UVA, some talk about UVA and B, and waterproof or not waterproof. So it's very confusing when you walk into a sunscreen aisle today. So to start with the type of sunscreen, you want to use a broad spectrum. So you want something that covers both UVA and UVB rays. I think that is the primary thing that you want to look for when you look for a sunscreen. The next is the SPF, or the sun protection factor. So it's interesting because that question is certain to a certain, you know, to a point. It is true that you want a higher SPF, but there's a cutoff. So if you have an SPF of 15, 1.5, it gives you about a 93% protection from the sun's UV rays. Now you up that to an SPF of 30, your protection actually goes up to 97%. So that's a big jump when it comes to medical terminology. But then when you go from SPF 30 to SPF 50, 50, your jump is only 97 to 98%. And then you have these SPFs of 100 that just give you about 99% protection. So if you notice, the jump from 15 to 30 was big, but really after that, it's not very big jumps. So if you're using an SPF of a minimum of 30, you're probably covered really, really well. So, you know, the higher the level of the SPF is correct till about 30 to 50, but anything higher than that is truly more of an advertisement gimmick to, you know, make you feel better. What's important is that you want to apply the sunscreen to your entire body. You know, if it's a liquid sunscreen, you want to kind of take about an ounce and apply it to your entire body, ideally about 30 minutes prior to heading out into the sun. And then you should reapply every 2 hours. You should also reapply whenever you go take a dip in the pool or in the ocean and you come back out. Even if the sunscreen says waterproof, that is not a guarantee that you have an even amount of sunscreen over your body after you take a dip. So definitely reapply. There's other forms in which you can, you know, kind of keep yourself safe. So when you talk about prevention, although we emphasize the sunscreen part of it, there's also other things that you can do. You know, seek shade. We just talked about the UV rays being the most prevalent between 10 a.m. and 4 p.m. You know, I'm not going to tell you to go before 10 a.m. or after 4 p.m. to the beach. You know, that's probably the most fun time, but try to stay in the shade as much as possible. You know, maybe get your own umbrella or rent an umbrella or find a patio where you can hang out. Also, while you're out there, you know, use some sort of a full covering, some sort of a shirt or something, that a light shirt that you can wear while you're out in the sun. Try not to burn. You know, that picture there with those you know, blisters just makes me cringe, because that's really dangerous. You know, talk about a blistering sunburn. You know, even once or twice every couple of years almost triples, 3 times triples your risk of melanoma in your lifetime. Also, please avoid tanning beds. You know, I've tried to say this before, I'm going to say this again. Giving yourself a base tan does not protect you from developing skin cancers. A tan is your body's way of signaling your skin is getting damaged. So avoid that. Again, cover up with clothing. As boring as it may sound, it's probably better that you wear a swimsuit or even a light throw on while you're out in the sun, even if you're under the shade. We've noticed in more recent times that even with the application of sunscreen, I'm having more and more patients come in with sunburns, and they're like, Dr. K, I promise I had applied SPF, 30, I had applied SPF 50, and they come in, red as a lobster and burnt. So you have to be careful. You have to take additional precautions and cover up, especially children and babies. They don't really realize by the time they get burnt, it's already too late. So, give them a swimsuit that'll keep them covered, give them a nice broad brimmed hat. You should be wearing some sort of a hat and maybe sunglasses to protect your eyes, because a melanoma of the uvea, so your inner lining of the eyes, is also a very dangerous form of melanoma, and definitely not something we can, cover in this time. So, as with prevention for any other type of cancer, it's the same thing over here. Examine, examine, examine. Routine skin exams are an absolute must. Ideally, every month you should be examining yourself. Get undressed in front of a mirror, look at the front and the back. Ask your spouse or your significant other to take a look at the back, and keep an eye on especially hot spots. So anything that looks like it's evolving, you want to keep a very close eye on that. And then ideally, at least once a year, you should be getting a physician to look at you from head to toe. So if your primary care physician feels comfortable doing that, or you seek out a local dermatologist, and they will literally look at you. I mean, this picture is not an exaggeration with a magnifying glass. They will use special instruments like dermoscopes, and they will take pictures so that they can record the development of some of the more concerning appearing moles.
Well, prevention is really key. You just said it. Prevention in so many forms of cancer is critical. And unlike some cancers where you can't necessarily control your gender and we haven't figured out how to stop aging, so cancers that increase with age, we can't do much about that. But for skin cancer, so much of this is within our control. And that, I think, is a really empowering message for us to hear. So before we move on to some questions from our audience, I want to close out with your final thoughts. What's the verdict? Sun, friend or foe?
Now you're trying to give me the trick question. So, as with most things in life, right? Anything in excess is probably not good, whether it's sugar or alcohol or smoking or any of that is not good. Same thing with the sun. The verdict is moderation. You want to be out in the sun, but with adequate prevention, adequate protective measures. So the American Cancer Society, tagged this very interesting slogan. It's the slip, slop, slap, and wrap. And it's a very nice way of reminding patients what to do. So you slip on a shirt, slap on some sunscreen, slap on a hat, and wrap on sunglasses. So it's kind of covers everything that you can do while you're out in the sun to protect yourself.
Well, this has been an incredibly informative 45 minutes or so. Thank you, Dr. Kulkarni, for this formal part of our presentation tonight. And we do have several questions from the audience, which I thought we would. So let's go ahead and use our last 10 minutes here to go through some of those questions. So here is one related to SPF. If I use a higher SPF, can I stay in the sun longer or get away with not reapplying?
Unfortunately not. So I think we went over this just a couple of slides ago. Your higher SPF is not necessarily giving you a much higher level of protection. So, if you've got an SPF of 30, sure, you've got about a 97% protection. If you go to an SPF of 100, it just goes to, about 99%. So it doesn't really give you that much more in terms of how long you can stay out in the sun. On an average, if you see, the range is from the lowest is 93%, the highest is 99%. So, and that gives you approximately 2 hours in the sun if you have applied it at least 30 to 45 minutes in advance. So, no.
Lots of questions about sunscreen. We're all confused on what to do with sunscreen. And if you're like me, you're kind of looking for a way to maybe get away with something. So we'll answer a couple more of these. You touched on this a little bit, but I think it bears repeating. One of our questions here, I'd like to have some color. Is a low SPF a safe way to get tan while also preventing skin cancer?
Um, Again, not really. I mean, a tan is your body's way of signaling that your skin is getting damaged. So you go out there, and you want to get some color. It's true. It makes you look good, but that's actually your body telling you, my DNA is damaged. So use the sunscreen. You'll probably still get slightly tanned, because ultimately you're out in the sun, you're gonna have some sort of a tan, but don't use that as a kind of a mental satisfaction that that's going to prevent any future skin cancer. When you start getting tanned is probably your key. All right, let's step back, stay out of the sun a little bit, or get inside some shade, or pull on that, that throw. It's that's your warning sign.
This one kind of follows the same suit, but it's a slightly different take on it. So I'll just read it out here, but I think you've answered it. The question was, I work outdoors and I've built up a tolerance to the sun. I don't burn. Do I still need sunscreen? And from everything you're saying, unfortunately, the answer is yes. I think we all need to take that away. Sunscreen every day. That's what we need to do.
Carry a spray for that reapplication, because if you work outside, if your job is, a landscaper or a roofer, siding person, you're out there all the time. The best way is to wear a full length shirt. As horrible as it may sound, you have these moisture wicking shirts that you can wear, and there are actually some that are have some degree of UV protection too. So if your job requires you to be outside, you may want to kind of, look into some of that type of clothing to protect you. A hat, sunglasses, and maybe like a spray-on sunscreen for the reapplications.
There is actually a question, interesting that you mentioned that, about the UV protective clothing. So does that actually work? Does that give you added protection? Or again, is that a gimmick like the SPF 150?
I think again, as long as you're keeping yourself covered, UV protected or not, probably not a big difference. But for someone who's already, for example, has had a diagnosis of melanoma and still works outside because that's their profession, it might give a little bit of added satisfaction and protection to have some of these shirts that are UV protected. But the bottom line is, if you've kept yourself covered and you're applying sunscreen, you've probably done what's the minimum you can do.
Okay. Here's another one, slightly different question on sunscreen. Doesn't sunscreen have harmful chemicals? Is it safe for use? I mean, certainly it would prevent skin cancer, but are there other risks with sunscreen?
Yeah, I'm definitely, well, skeptics, one of the skeptics of any form of chemical on or inside your body. But the fact is that, when you have a sunscreen that's out on the shelf, it's out there because it's FDA approved, and we do trust our Food and Drug Administration to go over that, the products with a fine tooth comb. They have to go through several trials before they ever hit the shelves and are FDA approved. So if you're looking at an FDA approved sunscreen, the chances are that the chemicals in that sunscreen have been ratified by the FDA as safe for you. And kind of, boils down to one of those risk benefit ratios. What is the risk of me being out there in the sun for 5 hours and getting burned, as opposed to applying a sunscreen, which may expose you to some of these chemicals that have not been shown to develop any sort of, harmful effects, at least to this point. If you're very, very nervous, there are some zinc-based or titanium oxide-based sunscreens that, have a more kind of natural, mineral-based tone to them, and you can use those.
Got a lot of questions. They keep coming. I can't get through all of them, which is great. Any kind of special sunscreen you should use for your face, or is it pretty consistent?
Um, it's pretty consistent. I would say, with the face, especially for women, I know, you don't want to go out there with this greasy sunscreen, so you tend to look for something that may be blended with the makeup. You should be aiming for an SPF of 15 to 30 at the very least. So, if your makeup is advertising anything less than that, and talks about being the ultimate in skin protection, it's probably not telling you the truth. So you look for something that's at least SPF of 15 to 30 in your makeup, but pretty much the rules are the same.
And are most sunscreens today broadband? When they say broadband, does that mean they cover all of the UV ray types that you outlined?
Yeah, I would say most of them are, but I would still check on the bottles to make sure that they are, UVA and B compliant, UVA and B protective. The UVC rays, we don't focus on as much because the maximum damage is caused by the A and B. So look, when we talk about broad spectrum, we're talking about coverage for at least those two.
Okay. Couple questions about precancerous. Do you think that precancerous moles should be excised?
Absolutely, absolutely. So, in the natural cycle of the development of cancer, you start from a normal cell that becomes mutated, that then develops hyperplasia. That means the body's kind of slowly producing more without getting rid of it. And that's the essential term for a tumor. When that goes into hyperdrive, you start developing the precancerous cells, which, if left alone over a period of time, will start invading through the deeper tissues, and that makes it invasive cancer. So if it can be removed in the precancerous stages, it can be removed with a much smaller margin. It's surgically, far more cosmetic, and more importantly, you're rid of the cancer, the possibility of developing a cancer.
And then we had a clarifying question on a term that you used. Can you clarify for the audience what the term in situ means when you relate to skin cancer?
Sure. So, the difference between pre-cancer and cancer is its ability to invade through a basement layer. So in the case of the skin, as soon as it crosses that basement layer, it becomes invasive. So when the tumor cells are proliferating, when they are multiplying, but they haven't yet crossed the basal layer, that's the precancer, or what we call in situ. In situ meaning staying in place. When it starts invading, then it's invasive. So precancer or in situ is literally a step away from the development of invasive cancer.
Okay, a couple more questions here. What are the best foods to eat to protect the skin?
Um, I think a healthy, kind of mixed diet um, is adequate. You want your inner ability to produce vitamin D to be enhanced. So, anything that does that, that has a high content of calcium and vitamin D, helps your bones. But for the skin per se, plenty of water and fluids, an adequate mix of greens and other types of vegetables with some meat. If you're a vegan or a vegetarian, obviously that's out of the question. But I will emphasize on the plenty of water part.
Great. All right, we have just a couple more questions here, and we're just coming up on time. But I think this one is an interesting clarification. So there's a question: do melanomas only come from moles, or can you have melanoma without having a mole that turns cancerous?
Yes, absolutely. So, mole is kind of a ready to go, substrate, if you may, for the development of melanoma. So if you have a mole, that's more likely to kind of, get affected and develop into a skin cancer over a period of time. But that does not mean that you cannot develop a new lesion all by itself. And that comes from the sun damage. And, it could be a completely new lesion.
All right, just two more questions. This one is specific to a toddler, but this probably can happen to adults too. My toddler's eyes get bloodshot after beach days. Could it be a sunburn? And any suggestions for protecting eyes in kids? This can be tough. You try sunglasses, that doesn't always work.
Yeah, so in kids, although this may not be exactly equivalent to a sunburn, but it is an indication again that there has been too much exposure. Like you rightly said, in a child, sunglasses are probably it'll take some very creative parenting to keep those sunglasses on. I know I couldn't, but a broad brimmed hat will help to protect the eyes. Keeping them in the shade, as much as possible will also help them protect their eyes.
All right, and then just one final question, which is probably a good wrap-up reminder point for us. Do you always recommend a dermatologist to evaluate or treat skin cancer?
So there's multiple ways to skin a cat, so to say, right? So a dermatologist is experienced and has the kind of tools to go over a head-to-toe screen. But the fact is that in real life in the community, there are a lot of primary care physicians who've been doing this for several years and can be your first guard against the identification of the development of a concerning lesion. So yes, if you have especially the more sensitive skin types, if there is a family history of skin cancers, or you have a personal history of a skin cancer, then you should absolutely be seeing a dermatologist 1, maybe even 2 times a year. But if you have no family history, you've never had any precancerous or cancerous changes, and your primary care physician seems comfortable with monitoring you, that's an acceptable solution too. And that's a conversation you need to have with your PCP and say, Doc, do you think you would be comfortable monitoring my skin as well, or should I seek out a dermatologist? And I'm sure they will guide you.
Very good. Well, we actually were able to get through all of our questions here. We do have one nice comment I want to share for you, which was a thank you for a most informative and interesting presentation. This anonymous attendee learned a lot, so thank you very much for that feedback. And Dr. Kulkarni, I would like to thank you for taking your time out tonight to share this information with us. It's such an important topic, especially as we're heading into the July 4th holiday. So hopefully all of our attendees follow the slip, slap, slop, and wrap. I think I got them all right. They might be in the wrong order, but that's a great mantra for us to live by. So thank you again for your participation tonight. To our audience, thank you so much for tuning in. We really appreciate you taking the time. Stay safe, stay healthy, and be well. Thanks so much.
It was an absolute pleasure. Stay safe.